presenting drug dosing in a renal replacement therapy. So first, I would like to go through the basics, this kind of revision. So with the major renal replacement techniques are divided into intermittent, hybrid, and continuous. In intermittent techniques, we have this intermittent hemodialysis, isolated ultrafiltration. In hybrid techniques, we have sustained or low efficiency daily dialysis, that is SLADs, and sustained low efficiency daily dialysis with filtration. In continuous renal replacement therapies, we have continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, then continuous veno-venous hemodiafiltration, and slow continuous ultrafiltration. So there is this three compartment model of the hemodialysis, which uh, consists of intracellular space, extracellular space, and the circulating blood volume. So whatever the fluid and the toxins which are produced in the intracellular space, that will be transferred to the extracellular space, and uh, that will be get. Hello.
Sital, continue.
Yes, sir. And from the extracellular compartment, these toxins will be transferred to the circulating blood volume, that is intravascular space, and through which, with this, the dialysis will try to remove this toxins out of the body. So this compartment model for the hemodialysis, hemofiltration, and hemodiafiltration. So as we see in the diagram, so this hemodialysis, it is only dialysate which is coming out. In hemofiltration, it is ultrafiltrate which is coming out, and we are uh, replacing it with the replacing fluid while to the patient, while blood going to the back to the patient. And with hemodiafiltration, it is dialysate and ultrafiltrate, which is coming out of the patient's body. So this comparison of different methods of dialysis are with the duration, dialysis flow, blood flow, urea clearance, hemofiltration, and hemofiltration rates. As we see in the sustained low efficiency dialysis, that will be around 100 ml per minute, and continuous veno-venous hemodialysis, it will be 20 to 40 ml per kg per hour. So back to the basics again, with regard to the drugs, we should know about the pharmacokinetics and the pharmacodynamics of drugs
सोनू से बात कर लिया मैंने सोनू से
before
बात कर लिया है मीटिंग में हूँ हाँ
before considering the drug dosing in the renal replacement therapy. So pharmacokinetics is how human body acts on administered drug, that is absorption, diffusion, metabolism, and excretion. And pharmacodynamics is what the drug does to the body. That is enzymes, transmembrane ion channels, membrane-bound transporters, and the receptors. So this is the pharmacodynamics and the pharmacokinetics. So the loading dose of the drugs depends on the drug's volume of distribution. So water, like hydrophilic, or whether the drug is hydrophilic or lipophilic. How the drug is binding of the protein is there, and tissue permeability, extracellular volume, and blood delivery, and microenvironment pH. The loading dose of the drug will be depending on all these factors. With increased, if the volume of distribution is increased, then we should increase the drug doses. And if the volume of distribution is low, then we have to decrease the drug doses. So volume of distribution is it is a theoretical volume through which the drug is distributed if the concentration throughout that volume is the same as the plasma. So it is a theoretical concept considering as a whole body as a one single compartment. The maintenance dose of the drug will be dependent on metabolism of the drug, like whether it is primarily hepatic or primarily kidney or hepatic excretion. So, if it is increased metabolism, then we need to increase the maintenance dose of the drug. If the hepatic metabolism or the other metabolism has decreased, then we need to decrease the drug doses. So excretion through the kidney or hepatic, if excretion is decreased, then we may need to adjust the drug doses. We may need to increase the interval of the dosing or combining of both, like decreasing the dosage and increasing the interval. If the excretion is more increased, then we may need to increase the dose and we may need to give the drug frequently. So all these things are required during a renal drug dosing with the renal replacement therapy. So we have to readjust the drug loading and maintenance dose based on the changes in the clinical status. So the why drug dosing is difficult in critical ill patients. So there's unpredictable situation. Then pharmacokinetics of the drugs changes in the critically ill patients, and there are extracorporeal drug removal, like enzymatic drug removal. So what are the unpredictable situations? So like unpredictable situations in the sense the critical ill patients will have some variable residual renal clearance and there will be altered pharmacokinetics um, due to critical illness or sepsis, multi-organ dysfunction due to resuscitation, and there will be some changes in the clinical scenario, whether it is improving, deteriorating organ dysfunction. So it's always unpredictable situation in terms of drug dosing to the patient. So altered pharmacokinetics, there may be decreased clearance, maybe either renal or hepatic, or there may be increased volume of distribution, and uh, drug characteristics like depending on the clinical situations, whether it is sepsis or multi-organ dysfunction, and the physiological properties of the drugs like ionization, protein binding, then partition coefficient, particle size, and the pharmacokinetic properties like half-life, clearance, and volume distribution. So drug factors like volume of distribution, the solubility, whether hydrophilic or lipophilic. Then drug factors like volume of distribution, protein binding, then active metabolites of the drugs, or the clearance of the drugs will be considered while drug dosing in the um, critically ill patients in RRT. So what happens in the sepsis is there's increased cardiac output, so increased clearance of the drugs, and there will be low plasma concentrations, and we may not be able to achieve the desired therapeutic drug concentration, which we want in the critical ill patients. There will be some leaky capillaries or altered protein binding, again will increase the volume of distribution in such patients and leading to low plasma concentrations. In end organ dysfunction like renal or hepatic, there will be again decreased clearance of the drugs, and there will be high plasma concentrations of the drugs. So we have to balance in both situations. So, implications of MORS in antimicrobial pharmacokinetics. So, in critical ill patients with multi-organ dysfunction, there will be GI dysfunction, which leads to decreased absorption of enterally administered medications. There will be tissue hypoperfusion causing decreased antimicrobial tissue concentration. And due to hepatic dysfunction, there will be decreased protein binding of highly protein bound drugs and decreased metabolism of lipophilic drugs. With renal dysfunction, there will be decreased elimination of hydrophilic drugs. So, with hepatic dysfunction and the renal dysfunction will leading to overdosing of the antibiotics, antimicrobials. And with the GI dysfunction, tissue hypoperfusion, and hepatic dysfunction with decreased protein binding, it may lead to underdosing of the antimicrobials. So this is again one basic pharmaco pharmacology revision. It's this diagram is showing area under curve and a minimal inhibitory concentration. Like for example, the like concentration dependent antibiotics like aminoglycosides, then the time dependent beta lactams, and the other like fluoroquinolones, which are concentration with the time dependent antibiotics. This so pharmacodynamic properties that correlate with the efficacy of selected antibiotics. So this beta lactams, carbapenems, linezolid, erythromycin, clarithromycin, lycozamides, they are time dependent killing characteristic of the uh, organisms, while this aminoglycosides, metronidazole, fluoroquinolones, telithromycin, they are concentration dependent, while the others, one like azithromycin, tetracyclines, glycopeptides, they are concentration dependent with time dependence. So, with hydrophilic antibiotics, so this general in general population, the pharmacokinetics will be like with low volume of distribution and the predominant renal clearance and low intracellular penetration. In altered ICU patient, altered pharmacokinetics in critically ill patients, there will be increased volume of distribution, increased clearance, or decreased may be dependent on the renal function. Like examples are like beta lactams, aminoglycosides, glycopeptides, linezolid, and colistin. On the other hand, lipophilic antibiotics, which have high volume of distribution in general population and predominant hepatic clearance due to lipophilic characteristic and good intracellular penetration, but in with such antibiotics with ICU settings with altered pharmacokinetics, this volume of distribution may be unchanged, but then again clearance of the drugs may be increased or decreased depending on the hepatic function. The examples of such antibiotics are fluoroquinolones, macrolides, lincosamides, tigecyclines. This is again the same thing, increased volume of distribution with the uh, maximum concentration of the drugs and the area under a curve. The factors that affect the pharmacokinetics, same, the protein binding. Drugs that are highly protein bound, like warfarin, diazepam, propranolol, phenytoin, are only cleared by renal replacement therapy in small amounts. However, as the patient's protein levels fall, the free fraction of the drug increases, and so does its clearance. The size of the drug molecule and mode of renal replacement therapy, that is convective versus diffusive. In this, small molecules less than 500 Daltons are cleared by all types of renal replacement therapy. But as molecule size increases, diffusion becomes less effective. Then timing of renal replacement therapy, that is intermittent versus continuous. So drugs given between sessions of intermittent hemodialysis or SLAD will not be cleared until the subsequent sessions. Dose of RRT, this reduced flow rates or shorter sessions will reduce the clearance of the drugs. The membrane permeability, high flux hemofilter membranes used in CRRT are permeable to most of the non-protein bound drugs. Then patient's residual GFR, which also needs to be taken into consideration. uh, the factors affecting drug clearance in hemodialysis will be then, as I said, type of membrane, characteristic of drug, concentration gradient across the membrane, and the rate of flow with which we are dialyzing the patients. So, in overall, in nutshell, the determinants of drug removal during continuous venovenous hemofiltrations are molecular weight, protein binding, volume distribution, lipophilicity, renal elimination, and with the dialysis perspective, filter material, pore size, surface, then blood flow, ultrafiltrate flow, post dilution or pre-dilution, and other patient-related characteristics as acidosis, alkalosis, changes in body fluid, or non-renal elimination and tissue perfusion. So, factors contributing to the difficulties in establishing precise guidelines for antibiotic dosing in critical ill patients with acute kidney injury. So, there are differences in baseline characteristics like age, sex, body mass, and surface, fat tissue, and muscle tissue content. This altered drug pharmacokinetics, that is, there will be all individual variations, there will be changes in volume of distribution, which is totally unpredictable. Then hypovolemia in critical ill patients, then changes in renal clearance. This commonly observed disturbances in drug metabolism in the liver, that is also will individually variability in ICU setup. Dynamic changes in the patient's clinical state and organ function. And the other factors which contributes to again difficulties in proper drug dosings are renal replacement therapy, which we are using various techniques and their modifications. There's difference in ultrafiltrate and dialysate flow rates. Various dialysis membranes are there and varying treatment times. How we can like potential dosing solutions for this altered antibiotic pharmacokinetics and pharmacodynamics in critical illness ill patients is if this larger volume of distribution with in patients in AKI requiring CRRT, so appropriately weight adjusted loading um, doses individualized to the specific patient based on physicochemical properties of the medicine, intensity of the CRLT, and native renal function. Uh, and a target dose monitoring will be also important for such patients. Then, in such patients, increased total daily dose we can increase, and more frequent dosing, we can increase the frequency of the dosing, that is, shorter the dosing interval, or continuous or extended infusions of the medicines with targeted dose monitoring. If altered ultra a fraction of the pharmacokinetics, then we can give the larger loading doses. We can increase the frequency of the dosing, or we can use the continuous or extended infusions. If reduced bacterial susceptibility is there, then we can increase the total daily dose, continuous or extended infusions, or application of this pharmacokinetic or pharmacodynamic models, and with targeted dose monitoring of the antibiotics, maybe early in the uh, treatment course. So step how we can go with the adjusting the drug doses stepwise for the patients with the CKD and AKI is first we can obtain history and relative demographic or clinical information. We can estimate the GFR. Then we can review the current medications. We can check whether any nephrotoxic medicines or narrow therapeutic drug uh, like lithium or dioxin are going on. We can monitor the drug levels and we can revise the regimen. So, drug dosing considerations for patients with acute kidney injuries. So, we should whatever the criteria we are known, KidGo, AKI, AKIN, rifle criteria should be prospectively utilized to optimize the identification of the patients at highest risk of developing AKI. The high risk medications, those with known nephrotoxicity or other potential toxicities associated with supratherapeutic serum concentration, should be identified proactively. For example, computerized order entry or electronic medical record. The volume of distribution of several medications is dramatically increased in the presence of acute kidney injury, and thus larger loading doses may need to be administered to avoid subtherapeutic responses due to the
हाँ मतलब
achievement of
हाँ
lower than desired serum concentrations. When possible, therapeutic drug monitoring should be utilized for those medications where serum drug
हाँ वो
concentrations can be obtained in a clinically relevant time
हम्म
frame. Then, trends in renal functions
रिकार्डियल
indices,
रिटार्ड दे दो उनको 20 मिलीग्राम देने
such
के
as
लिए बोलो
serum creatinine, urine output,
हाँ
along with the volume status, should be utilized to guide the
स्टार्ट देने
drug
के लिए
dosing
बोलो हाँ
when rapidly measurable indices are
ठीक है
unavailable.
ओके ओके
For those medications where therapeutic drug monitoring is not possible, we can closely monitor the drug pharmacodynamics may prove to be a useful surrogate for identifying the drug injury. Evaluation of risk for drug and drug nutrient interaction should be facilitated by incorporating validated electronic drug interactions tools into EMRs, as we have in our hospital. A patient centered team approach that includes an ICU pharmacist is recommended to prevent medication related problems and enhance safe and effective medication use. EMIs should maintain records for discontinued medications for up to 7 days to make it possible to assess potential residual effects on the patient's current condition. Then, drug dosing consideration in hemodialysis. So, the dose should be given after dialysis. Hemodialysis dose should be given after dialysis to ensure active drug levels until the next dosing. So, we can consider a supplementary dose in addition to the dose adjusted to the kidney failure after dialysis to replace the fraction removed by dialysis. So, supplementary dose derived from the studies of low flux non-synthetic membranes should empirically be increased by at least 50% when patients are dialyzed with high flux synthetic dialyzers. Then, extended dialysis regimens with high diffusive membranes have been associated with extensive drug clearances, and thus, uh, supplementary dose may need to be increased. Drug dosing considerations for acute kidney injury patients who are receiving CRRT. So, end stage uh, renal drug dosing recommendation should be used only as an initial guide for the initiation of therapy in AKI patients receiving CRT when no other information is available. The existing maintenance dosing recommendation for such patients receiving hemodialysis often result in achievement of subtherapeutic concentrations and treatment failures for patients with severe AKI requiring renal replacement therapy. The most effective dosing optimization strategy is to use target dose monitoring for drugs like aminoglycosides and vancomycin. However, very few drugs have clinically useful turnout around time, that is FDA approved assets available. When CRRT clearance data are available, the current literature recommendation should be the logical starting dose for therapy. Different treatment intensities for CRRT um, in mark variability in drug removal, and thus this literature may not be generalizable across multiple CRRT prescriptions that are used in practice. We can calculate the total creatinine clearance based on the addition of patient's residual renal clearance plus expected extracorporeal clearance. This value can then be used to estimate a maintenance dosing regimen based on medication dosing guidelines specified for that resultant total creatinine range. Using these methods, most drugs will fall in the creatinine clearance of 25 to 50 ml per minute of range. Drug starts with the dose and dosing interval for a patient with GFR less than 10 ml per minute. That is anuric dose. We can start with the anuric dose of the antibiotic and make the doses adaptations based on the drug fraction expected to be removed by extracorporeal therapy. That is, maintenance dose is equal to anuric dose divided by 1 minus uh, extracorporeal therapy fraction dose. So dosing interval is equal to anuric dosing interval into 1 minus fractional extracorporeal excretion. Then we can start with a normal dose of the antibiotic and reduce the dose based on normal clearance, non-renal clearance, effluent rate, and sieving coefficient with this formula. Then antibiotic dosing in slow extended daily dialysis. The infectious diseases and critical care specialists should communicate directly with the nephrologist regarding the type of dialysis being administered to the patient each day. Non-nephrologists should be aware of the terminology and essential differences between the various dialysis modalities. Physicians writing antimicrobial orders for these patients should speak directly to the nursing staff to ensure that post-lead doses are administered. As a general rule of thumb, for patients undergoing SLIG for 6 to 12 hours per day, renally cleared antimicrobial agents should be adjusted as they would be for continuous renal replacement therapy, namely creatinine clearance of 10 to 50 ml per minute. But the current recommendations for continuous renal replacement therapy. For antimicrobial agents normally administered every 24 hours that experience significant removal during dialysis, consideration should be given to administration of supplemental dose immediately after SLADE or simply to administration of the daily dose after SLADE each day. For antimicrobial agents normally administered every 12 hours that experience significant removal during dialysis, the dose should be given after SLADE and 12 hours later. Serum trough levels of antibiotics like vancomycin, gentamicin should be measured immediately after SLADE to determine the need for a post-SLADE supplemental dose. These are antimicrobial dosing recommendations during SLADEs. Anidula fungal, these are just examples. Anidula fungal, no dosing adjustment necessary. This daptomycin dose every 24 hours on SLADE, dose every 48 hours off SLADE, like that way. The drug dosing considerations, end stage renal disease dosing recommendations, this should be the only initial guide. Then most effective dosing optimization strategy is target dose monitoring for drugs like aminoglycosides and vancomycins. When the CRRT drug clearance data are available, the current literature recommendation should be the logical starting dose for the therapy. Then another alternative is to calculate the total creatinine clearance. But the best and the most effective strategy will be using targeted dose monitoring. That is, sir. That is. Thank you, sir.
Any questions from the audience? Okay, Sital, go to the
yes,
first slide of yours.
First slide, yes, sir.
Second, third.
Yes, sir.
Just above that, number 3
Okay.
slide. So
This one,
first
sir?
of all, yeah.
Yes, sir.
So here there is a issue regarding the what has been already visualized in this
Yes, sir.
pictorial form. Okay.
Yes, sir. Yes,
So
sir.
when we are talking about the volume of distribution or how the water is distributed in our body, basically when we are talking about water soluble medications.
Yes, sir.
Okay.
Yes, sir.
So here it is very important. It is like you said, 3-compartment model, but the labeling is not correct. Okay, so we categorize them into intracellular space, then extracellular space, and in the extracellular space there will be two parts. One is intravascular
Interstitial,
space and interstitial space.
interstitial space.
Okay.
Yes, sir. Yes, sir. Yes,
So
sir. Yes, sir. Got it, sir.
so intravascular space is basically part of extracellular space.
Extracellular space. Yes, sir. Yes, sir.
Okay. So
Yes, sir.
when you talk about the how much is the intracellular then
Hmm.
component, so two-third is the intracellular component, then one-third is the
One third is the
extracellular component,
extracellular. Yes,
out
sir.
of
Yes, sir.
which the interstitial is three-fourth and one-fourth is intravascular.
One fourth is extra.
So
Yes,
likewise.
sir.
So
Yes, sir.
basically what we are doing at this moment is we are dialyzing from the intravascular space, and that
Hmm.
is just one-fourth of the extracellular compartment.
Hmm.
Correct.
Yes, sir.
So
Yes, sir.
most
That
of
is
the
very less
very
volume.
less. Correct. However, when we are talking about the drugs, obviously they
Hmm.
will have a, if it is a water soluble drug,
Hmm.
then it will be distributed evenly in the intracellular compartments as well as extracellular compartments.
Extracellular. Yes, sir.
So what happens is when the concentration in the intravascular space goes down,
Hmm.
so in that scenario there will be a gradient, concentration gradient.
Hmm.
And the cell membrane is the main part which is causing this concentration gradient from the intracellular to the extracellular space and from
Hmm.
the interstitium to the intravascular space. Okay.
Yes.
So
Yes, sir.
when you are taking out through dialysis or any type of renal replacement therapy,
Hmm.
you are reducing the concentration of the drug
Hmm.
by dialysis, and there is a gradient which has been created for which the toxin will be moving or the drug
Cells.
will be moving from the intracellular space to the extracellular interstitial space and then goes to the intravascular space.
Yes, sir. Understood.
Okay, so that
Yes.
is the first one. Second one is you need to know also what are the order kinetics. So first order kinetics,
Okay.
zero order
Zero order
kinetics,
kinetics. Yes, sir.
and
Yes, sir.
also the second order kinetics or elimination kinetics. So
Yes, sir.
what are those? Can you describe?
Yes, sir. So, first, first order kinetics is the
First, the zero order kinetics. What is zero order kinetics?
zero order kinetics is the same amount of the drug is excreted at every t half of drug elimination.
It is not T half. It is at a certain time frame, a constant amount of drug is
Constant.
getting eliminated.
Yes, sir. Constant.
Okay. So basically, you will see that when you put it in the chart, you will see that in the zero order kinetics, it will be a straight line.
Huh. Yes, sir.
So that is a straight line.
Yes,
So
sir.
at a certain time frame, you are basically your drug is getting excreted out by or metabolized by the body, and it is a certain constant amount of concentration
Drug.
of drug is getting out.
Yes, sir.
Okay, so that is called a zero order kinetics. The first order kinetics is that you are taking out the drug,
Mhm.
but there is additionally, let us say that it is getting out by kidneys and liver both.
Hmm.
Okay, so it will not be a straight line. It will
Hmm.
be like a hyperparabola.
Like it will decrease, the rate of elimination will decrease
Yeah,
with the
but it
time.
will not be
Hmm.
constant. It will be variable.
Constant.
It
Yes, sir.
will be variable, but it will follow a course of hyperparabola. Okay,
Okay. Okay,
and
sir.
then the third order kinetics or the second order kinetics comes. That is, second order kinetics is basically those drugs which are undergoing enterohepatic circulation. जैसे कि one drug is getting metabolized and then excreted out by the bile and getting absorbed again. The active metabolites are getting absorbed again by the enterocytes and going back to the
circulation
again.
Okay.
So that is called as
Second
order kinetics.
Okay,
So likewise, so you have to know what are the types of, these are basically pharmacokinetic properties of a drug. Like you said, pharmacodynamic dynamic properties, that is a pharmacokinetic property.
Yes, sir.
Okay, so then you have done very nicely. Actually, it is more than enough for a general person to understand how you have done it nicely. Okay.
Thank you, sir. But I was a little short of like his slides were getting too much, so I thought I did not included the antibiotics like doses and individual antibiotics.
Yeah,
We
individual
can just
antibiotics, actually you cannot keep it in the one slide or in the yeah. So that is basically a you have to follow there are tables available. There are literatures available. How much is the dose has to be given, whether supplemental dose to be given or not, and all those things are basically available. There is a very good book that is I will show it to you.
Sir, you have sent me one book actually, but that was with the all the drugs and the dosage, adjusted dosage.
Yeah. So for the other people also, I need just showing you.
Okay, sir. And sir, what else? What else? I need to know in this topic with respect to exam plus understanding.
Volume of distribution you have nicely presented. That is very important.
Okay, sir.
So can you see it now? I'm just showing it.
Sir, no, it's not visible, sir. Is it this Davis Pocket Clinical Drug Reference?
No, no, no. It is drug prescribing in renal failure. That is by Aronoff.
Okay, sir, we don't
Drug
have that.
Prescribing in renal failure.
Yes, sir. I think.
George A. Aronoff.
Yes, sir.
So that
I will share this on the group, sir.
if you have, you can share it in the group.
Yes, sir.
That gives you a complete package basically. How much drug will be filtered, how much will be supplemental doses needed, all those, which are the drugs which need not be adjusted in renal replacement therapy. Let us say that digoxin. Digoxin is a drug which is highly protein bound. And in hemodialysis, it doesn't get excreted out. So there is no dose adjustment needed for digoxin except, and also it is a big trouble for us in the sense that if there is a digoxin toxicity, we cannot offer hemodialysis to take that drug out.
Yes, sir.
However, you can take out through hemodiafiltration, where convection is basically small amount, not much. It is basically a small amount. It is a protein bound drug. So, and this antibody against the digitalis, digibind is also not commonly available. So it is very difficult in those scenarios how to manage these people. And especially so in renal failure patients. Whereas phenobarbital, if you take into account, then it is completely dialysable drug. So phenobarbital is 90% to 95% is dialysable. Alcohol is dialysable. So in case of methyl alcohol
Okay.
poisoning,
Okay.
we dialyze the patient against alcohol dialysate. What is alcohol dialysate? The ethyl alcohol will be put in the part A solution of the dialysis machine,
Okay.
and then you do the dialysis. So what it will do, the ethanol will compete with the methanol to
Okay.
get attached to the receptors
Okay.
and displace the methanol from the receptors. So that way, that is the only way, means except omeprazole, this is another way by which you can take out the alcohol from the body. Okay.
Okay.
So that is one way, like drug adulteration happens, no?
Mm.
Cluster of people come with methyl alcohol toxic, yeah, uh, consumption. So in that scenario, it is a toxic drug. So it causes blindness, it causes arrhythmias, it causes death also, neurotoxicity also. So in that scenario, ethyl alcohol will be given. Yeah. So ethyl alcohol dialysis can be life-saving. So likewise, you will get enough information from that yeah, from that year. Just go and read about that also. Volume
Okay,
of
sir.
distribution you have to know. The
Okay,
volume of
sir.
which are the drugs which are having high volume of
High
distribution,
volume administration.
and which are the drugs which are low volume of distribution. Low volume of distribution are dialyzed well. High volume of distribution indicates that they are inside the intracellular compartment or
Mm.
in the interstitial compartment. So
Mm.
taking them out will be very difficult unless until you do a CRRT type of therapy.
Filtrations.
Yeah.
Okay.
Okay. And then you don't have to calculate the creatinine clearance in case of acute kidney injury when the patient is anuric. So we presume that
Mm.
the patient is already having less than 10 ml GFR.
Okay.
Or it might be so that the creatinine might be low in those group of patients, and maybe around 2 to 3 or something like that. That is due to the hemodialysis or hemodiafiltration or hemofiltration itself, the
Okay.
clearance which is there. So creatinine will obviously be not a marker when you are offering a dialysis to the patient.
Okay. And sir, one more thing, sir. Do we use these formulas which many books has given for calculating the uh, appropriate dose for the patients on the renal replacement therapy? Like they have given different formulas. Do we really practice that
Formulas
the
of
practice of the drug dosing on the renal replacement therapies? They have given multiple complicated formulas in the various books.
yeah, it is most commonly practiced with fluoroquinolones and aminoglycosides.
Okay. Okay.
And
Okay, sir.
all other antibiotics, actually, we don't know unless until you go through that and see the tables and
Okay.
see with that how much is the creatine clearance and then calculate.
Okay, sir.
And regarding another thing, when you said about 7 days, that is
Mm.
not correct. It is the
Okay.
five drug half-life. That is the
Okay.
complete.
To keep the record, the
Yeah, means the pharmacy, if there is a toxicity kind of thing,
mm.
you want to take out the drug which is
Mm.
there inside, especially maybe antibiotic or any other drug, then
Mm.
you have to see what is the T half of that drug, any
Okay.
antihypertensive, any
Mm.
other,
Mm.
yeah. So what is the T half of that drug? And
Okay.
to completely eliminate it from your body, it requires 5 half lives. So
Okay.
multiplied with 5.
Okay.
That is the normal norm.
Okay.
T half with in multiplied by 5.
5. Okay.
Let us say that uh, furosemide.
Hmm.
Furosemide, the T half is around 6 to 8 hours. Okay. So
Hmm.
6 hours into 5. So 20
Hmm.
hours, the furosemide will be zero concentration in your body.
Okay. Okay.
So that is and so few of the drugs are renally eliminated, few of the drugs are eliminated by bile and liver metabolism. So if their liver metabolism is all right, then there is uh, no need of drug adjustment. So go through it. It is a very difficult subject itself, but at least you should know the how it is getting eliminated, the drug getting eliminated, and how do you are going to adjust the dose. So that is an important thing. Okay.
Yes, sir.
Sure. Thank you so much, Shikha.